So each one of these will have a multiple choice question, and then we'll just kind of discuss it from there and see how it goes. So yeah, these are just some of these cases we'll touch on earlier lectures. Some of them won't. This one I don't think does, but this is a 69-year-old woman, had an incomplete optical colonoscopy earlier, same day, and now needs a CT colonography. And so even if you don't read these in your practice, you might be asked, if your partner reads them perhaps, maybe the text will show you a case like this, like what do we do next? These are the scout images. So on the left hand side and in the middle, these are supine AP and lateral scout images, and this is the prone image. And this was a new technologist after hours who probably had not done very many VCs. This was actually early in our experience too. And you can see the colonic distension is suboptimal. And we can see the rectal catheter. The rectal catheter has a little bright, bright tip to it, so it's a little denser. So we can see that's actually in place in the pelvis there, so that's fine. So why are we not seeing better distension? So, you're asked to QA these. First of all, we do give oral contrast after an incomplete optical and usually have to wait a few hours. They obviously didn't wait long enough. As you can see here, we have supine and prone images, and there's too much contrast in the small bowel. It obviously hasn't had time to even get to the colon. So that was kind of a waste. We did it a little too soon. But now let's figure out why are we not getting optimal or even adequate distension. So there's that bright tip from the catheter. So now we're seeing the catheter is in place. There's a pretty good air column there. But then it hits this soft tissue right here. And maybe abruptly, is that a mass lesion? Let's go over to the prone view and see what we think. I think the prone view actually gives us a better look at what's really going on. So don't forget to look at both series. So there's that bright tip to the catheter as we come down. Again, we're hitting this soft tissue mass or lesion. And then as we come down, there's you can see the rectum is filled with gas. It should meet up, but we come all the way down, and there's that catheter in place. There's the balloon probably for the catheter. And yeah, so now you're asked, okay, what do you do next? I mean, should we do a decubitus view? Should we, why is this suboptimal is my question for you. Is this incorrect placement of that rectal catheter? And now I'm giving you a sagittal view and a 3D view as well, which I'll explain later. Is this incorrect settings of the insufflator? Is it not maximized up to the maximum pressure, 25 millimeters of mercury? Is that an occlusive rectal mass, or is this a colon-containing hernia? So now let's see if we can switch over to the poll everywhere. And again, I'll abandon this if there aren't enough people participating in this. Go ahead and make your selection. We'll see how many. I think only 2 people responded to Tyler's question, if I was looking at that right. So if that's the case, I think we can. Oh, that looks like there's 10 folks. So go ahead and make your choice. I guess we have more than I thought. Maybe there are. No. So most of you think this is incorrect placement of the rectal catheter, but we're getting a nice array of responses. So that's good. Let's go back to my images here. And this is, in fact, incorrect placement. In fact, this is a woman, as I told you, and this is vaginal placement. You can actually see a very nice air vaginogram there. And that filling defect, that mass we're seeing is the cervix. You can see the external os there very nicely. And so this was actually more apparent on the prone view, but as we come down on the supine, we can still see, here's the cervix and the air vaginogram, if you will, and that catheter is within the air-filled vagina. And it's a little trickier on supine here because the rectosigmoid, the rectum is collapsed, which is often the case when it's not distended on the supine view. We saw it better on the prone view because it filled with air, but it did not connect with that catheter. So this is vaginal placement of the catheter. We had the patient come back. It was a little embarrassing, obviously, to see this the next day. We had the patient come back, still had remained NPO. Now the contrast is in the colon, so actually this is a better time to try to do this salvage virtual colonoscopy exam anyway. And now that catheter is in the very nicely distended rectum. The vagina is now collapsed anteriorly as it should be. And so this is, we ended up getting a very nice result, as I'll show you. These are scout images and the 3D map, so we were able to salvage that study. And just to show you again, so these are the images from 3D, kind of a nice endoluminal view from the air vaginogram. And this is just something to think about. It happens to maybe the best of us, or maybe all of us at some time. Here's a case from a first-year resident who will remain nameless. Many, many years ago, first rotation, I think. If you recognize that cuff, that's the big barium enema cuff that's double inflated here to form a really good seal for this, what kind of, this was me, I'm not gonna lie. So I was asked to do a gastrograph and enema on a morbidly obese patient. I had no idea what I was doing. I was, trying to get the catheter in place. I pumped up the cuff, and then I got these images. I thought, wow, there's, it's an abrupt termination. I even saw like a little additional kind of triangular structure here. And the patient obviously wasn't helping by suggesting I might not be doing the right study either. So at that point, Jay Hyken was running down the hall, and I figured it out just in time to be like, oh my goodness, maybe I'm not in the right spot. So this is what it looks like at fluoroscopy when you have vaginal insertion of the rectal catheter. Probably the best contrast vaginogram you'll ever see. Okay, so case 2. I actually read this study as well. This CT scan was done, true story, 49-year-old man with rectal bleeding. I'm going to show you a CT and MR images. So obviously we're going down through the distal, rectum here down into the pelvis. If we focus on the CT first, I think you can see there is some lobulated circumferential wall thickening, and there's also all these calcifications. So there's a couple of things you might think of here, and so maybe we need to look for alternative, additional findings to try to narrow our differential a little bit. There's also an MR that was done and also shows rectal wall thickening, and maybe you can see those hypo-intense areas that correspond to the calcifications. Obviously better seen at CT. But there's notice that left hemipelvis, there's, some interesting findings in the subcutaneous fat. Are those prominent vessels? Is that edema? It looks somewhat edematous. I mean, there's even scrotal wall edema there, but it looks a little more tubular and maybe serpiginous. So we have this combination of findings. Here's what, I'll just show you the endoscopic view. We get this kind of violaceous purplish hue to that wall thickening. Obviously can't see the calcifications, but on EUS, you can actually see some of these echogenic foci represent those calcifications, and there is circumferential wall thickening. And here's an image lower down. Maybe that thigh is a little bigger than the other side with some, with again, all these prominent vessels. So putting that all together, what do you think is the most likely diagnosis? Is this mucinous rectal adenocarcinoma? Certainly something to think about when you see calcification in the setting of kind of a low attenuation mass, and we'll look at that. Is this lymphangiectasia, perhaps, involving the GI tract and the left lower extremity? Is this Klippel-Trenaunay-Weber? Or is this a solitary rectal ulcer syndrome? So let's we'll go over and get the pull everywhere, and then we'll talk about this one a little bit. Give you a chance to make your best guess. Okay, excellent. Yeah, and most of you are on this. Again, we're seeing responses for all 4 of those, so that's, I guess that's, I feel like it's good that that we're up here going over these. Let's switch back to my slides, please. Okay, and this is Klippel-Trenaunay-Weber. It goes by various names. There's like Parks-Weber, Klippel-Trenaunay, sometimes with Weber, sometimes without. But this is rectal hemangiomatosis in the setting of Klippel-Trenaunay-Weber, which is a triad of, well, let me show you what the patient's lower extremity looked like. That left leg has a port wine stain. There are varicosities all over the place in that limb, which may be slightly bigger than the other side, so the hemihypertrophy is the third part. They can also get AV fistulas and other weird things that we saw in Doppler, which I didn't bother showing you, but it's not well known that GI tract involvement is seen in up to 20% of these patients with Klippel Trenaunay. So they'll get rectal hemangiomatosis. They can get, I've seen esophageal and small bowel involvement as well. It's those pelvic phleboliths that really, in the setting of this lobulated thickening, the endoscopic image, that purplish look is pretty typical for a vascular hemangioma type lesion. And what was the real fooler here? I think if you look at mucinous adenocarcinoma involving the large intestine, you certainly can get low attenuation involvement with or without those calcifications. So here's a right-sided colon tumor with calcification. Here's diffuse rectal wall thickening. This is a variant of mucinous adenocarcinoma. This is a signet ring type. So this is intracellular mucin, not extracellular mucin, as you might see in some of these other cases. But you can see that has punctate calcifications, and you can see that in the stomach as well, obviously, with a signet ring type adenocarcinoma mucinous tumor. It's a very infiltrative, aggressive finding, as Michael showed in some of those gastric cases. So there is a difference between intra and extracellular mucin, but they can both kind of mimic that look of a vascular lesion like hemangiomatosis. Okay. All right, moving on. Case 3. This is a great case I saw many years ago, 28-year-old woman. I'll withhold one laboratory value. But as we go through this case, she was presenting to the ED. Let's just kind of take this, we'll kind of dissect it. I think you can agree maybe there's some gastric wall thickening like Michael was showing. I think it's important to look at that attenuation. This is there's a little bit of artifact, maybe motion through there, but it looks low attenuation to me. So I'm thinking that looks inflammatory or edematous perhaps, so maybe this is a gastritis case, either primary or secondary. As we come down further, now there's something kind of odd hanging off the gastric antrum here. And I'll just point out this area right here. Keep your eye on this. It almost looks like a ductal structure. And then we get into this enhancing mass adjacent to the stomach. Let's just look at the rest of the case here. So there's looks like liver looked pretty normal. There's pancreas, that looks pretty normal. Spleen. That looks like it's in the right place. So all the other organs, kidneys, everything looks okay. So and then look at all that inflammation. There's free fluid and stranding all around that enhancing mass. So what the heck is going on? Let's go on to the next slide here. So what do we think this is? Is this perhaps wandering spleen? Is this omental infarction? We saw some cases of that, Michael showed. Is this Zollinger-Ellison syndrome, hypergastronemic state? Or is this heterotopic pancreatitis? So those are your options. I could give a bunch more options in a case like this, but okay, let's switch over to the poll everywhere then. It's actually a bit of an Ant Mini once you break it down. And we'll give a few moments for people that are playing along. There's at least, it looks like there were, yeah, is that true is that the number that there were 10 people responding, or do we get? Oh, great, we're getting a lot of response, okay. All right, so let's see where we are. Great, a lot of you. Okay, heterotopic pancreatitis is winning out. And let's go back to my slides. That is well done, because that's exactly what this is. It's in the classic location. The greater curve distal antrum is where most of these heterotopic rests will occur. And this patient's lipase was about 1800. So coming in with a normal orthotopic pancreas, as you'll see in all these cases, they all have a normal orthotopic pancreas, and everything else looks fine. But if you look off what's hanging off this inflamed stomach, and that's inflamed because of the pancreatitis that's involving this heterotopic rest, you can actually see this little primordial ductule. This is like trying to be a pancreatic duct that's emptying right into the gastric antrum there, and that's what these rests do. Sometimes you can get intramural pseudocysts, and that can fool you for other, like a duplication cyst. But this looks cottage cheesy. It looks like normal enhancing, or actually inflamed enhancing pancreas with pancreatitis. If you put that in the pancreatic head region, that looks just like pancreatitis, and that's basically what it is. But it's heterotopic. It's not ectopic, right? Because there is a normal orthotopic pancreas. It's heterotopic. So I think this is a spectrum of abnormalities. That top row is a patient who has groove pancreatitis, which basically are small ectopic rests in that pancreatic groove between the duodenum and the pancreas. Some people, I lump these together as part of this spectrum of heterotopic pancreatitis. And these can be kind of tricky because this is a patient that also had groove pancreatitis, has a little intramural cystic thing that 5 years later really progressed. And so what used to be called cystic dystrophy of the duodenum, I think almost all of these cases are simply just intramural pseudocysts related to pancreatic rests in the wall of the duodenum. So this is really just a spectrum, as we suggested in this review article, that this is just a heterotopic spectrum of findings. And so it really explains a lot of these weird cases where you'll see intramural cystic lesions in the greater curve of the gastric antrum. Here are some other cases I've seen. It can involve not only the stomach and duodenum, stomach most often, then duodenum. Here's a little pancreatic tail-like lesion hanging off a jejunal limb, and it looks inflamed. There's a little duct even. There's a normal pancreas, and then this was resected, and this is heterotopic pancreatitis off the jejunum. So think of that. If it looks like pancreas, it probably is. These can be a little trickier. Here's a mesenteric focus. And the differential is going to be more broad here, but when there's an elevated lipase, even though the pancreas looks normal, if you have something else inflamed hanging off a bowel loop, some portion of the GI tract, just think about it. And you can see that looks just like pancreas on the resected specimen. Actually, it looks a lot like inflamed pancreas on the CT. And then a case I saw more recently, actually our partner Matt Lee gave this to me, and here's this yet another jejunal involvement of inflamed heterotopic pancreas, and that was also resected. The pancreas, orthotopic pancreas, looked normal, and again, another case of heterotopic pancreatitis. All right, so I think we have time for maybe one or two more cases here. This is case 4. Okay, this was a 23-year-old patient who lived, these are all from our institution, but recently moved from south of the border, I'll say, that whether or not that clue helps, that may be a red herring, I don't know. Back pain, come to the ED, obvious, finding here in the liver, right? And if you follow that, look posteriorly in the back, you can kind of see how this process is kind of engulfing these ribs, and you can, not surprising that this could cause back pain, certainly. But it looks like it's centered in the liver, I would say. And then I'll just also have you look at that colon. It's going to be a little more obvious, I think, on the coronal views, but there is some so-called thumbprinting, I think. Those colonic folds are thickened, and it looks like it's involving primarily the right colon, I would say. Let's take a look at the coronal view. And also the scout and the abdominal, here's an abdominal radiograph. I think that shows the thumbprinting even nicer, that colonic fold thickening, which we can also see nicely on the coronal CT. So we have this abnormal colon, we have this large complex cystic thing in the liver that's invading posteriorly into the back and around ribs. So what do we think this is? Do you think we're talking about E. coli that spread maybe to the liver with a large abscess, maybe the O157H7, that nasty bug, enterohemorrhagic E. coli? Is this metastatic mucinous colon cancer? Again, low attenuation can kind of fool us for a cystic abscess, but metastatic disease can sometimes look like that. Is this amoebiasis from the Entamoeba histolytica, or is this an infected hepatic cyst, which I don't think explains the colon so well? And then I'm also throwing in an ultrasound image. You can see there's a debris fluid level in this really complex, thick-walled cystic thing that was, again, invading the back. Okay, why don't we go ahead and vote on that? lots of other options I could probably give you for a case like this, but we're trying to tie together that colon and liver. I think this kind of gets to even like the diverticulitis cases that can present subacutely with hepatic abscesses. Yes, this is amoebiasis or amoebic dysentery, if you will, right? So this patient probably had bloody diarrhea at some point, but now it had been going on long enough that there was a little residual smoldering colitis. Can we go back to my images? But it was mainly the liver and its complications now that was driving this. So this is one of these anchovy paste abscesses from, if you actually take it, it just looks like fulgurized, blenderized liver, basically. It's kind of nasty. And this is that single-celled organism that is going to cause the dysentery first and then spread via a portal route to the liver and created this abscess that was successfully drained, and the patient did well and had moved from Mexico, I think, several weeks earlier. Okay, well, let's do one more. Oh, wait, I also wanted to show you, just to round out our liver parasites, we heard about Clonorchus, the liver fluke from Frank. This is yet another fluke that it has a very interesting life cycle that actually, it gains access to the peritoneal cavity, it invades the serosal liver surface, and then dives in to find the biliary tree. I don't know, as if it knew what to look for. It eventually leaves this track. You can see in the case both on the left and the right, there's this sort of cystic tract it leaves behind until it finds the biliary tree. So this is fasciola, which is yet another parasite that can involve the hepatobiliary system. Very, very odd. And then there's schistosomiasis and others I won't go into. But let's just finish up with this last case, and then we'll do our Q&A, and that leaves lots of cases for me, perhaps for next year. So that I don't mind that. All right, this is a 25-year-old with intermittent pain and distension for many years. I think the finding is going to be pretty obvious here as we go through this. I'll just scroll up and down here. And then I would ask you to just watch out for just anatomically at the edge of this weird cluster of bowel. I'm just going to show you, this is the IMV coming down. Let me get this, coming into the portosplenic confluence here. So this is the IMV kind of hanging out at the edge of this cluster of bowel. So, and that's almost the entire, as I'll show you, it's almost the entire mesenteric small bowel contained within this encapsulated structure. So here's a small bowel follow through, and again, this is at just 25 minutes later, he's already in the colon, but you can see the entire mesenteric small bowel from the ligament of Treitz all the way to the very distal, maybe the terminal ileum, is all within this sort of contained packet. So I'm not going to ask you what the diagnosis is, because I think hopefully it's pretty clear. But what space is this internal hernia located? And I know I just said let's not worry about, I don't really like this question because it's getting into the minutia of things, but let's just get this out of the way here. What space? Do you think that's within the fossa of Waldeyer? Is this a foramen of Winslow hernia? Is this the space of Retzius? Or is this the fossa of Lanzert? And if we could just switch over, we won't take too long on this one because it's just kind of an anatomic question, but this is obviously a left paraduodenal hernia. And if you remember back from it looks like people, okay, good. I'm glad we're asking the question. Foramen of Winslow's winning out. Let's go back to my slides to finish up here. This is actually the fossa of Lanzert. So as I was trying to hint at, it's actually failure. I'll show some images of the left descending mesocolon to fuse. So you get this, the IMV, the inferior mesenteric vein, forms the free edge of this space, this fossa, that bowel can kind of penetrate into and maybe enlarge over time. But this is by far the largest left paraduodenal hernia I've ever seen. These sometimes are not that symptomatic, but in young children you might see a symptomatic case. This patient was mildly symptomatic, and it kind of looks like almost abdominal cocoon in some ways, but this is just a internal hernia. Another named internal hernia is the right paraduodenal hernia, which I always find very confusing. But what's happening is it's bowel going under the SMA from left to right under the duodenum. So in this case, as I'm showing you on the left, there's duodenal obstruction at the third portion by this bowel loop that's kind of tunneling under the duodenum behind the SMA, and you shouldn't have bowel under there, obviously, except for the duodenum itself. On the right is just another example. That was a larger hernia sac, but the right paraduodenal hernias are much less common. They're much more difficult to understand and conceptualize. The left paraduodenal hernia is a pretty easy one. Maybe next time I'll show you a Freeman and Winslow hernia where it gains access to the lesser peritoneal sac between the portal vein and the IVC. That would be higher up. And it would be contained in the lesser sac, which this was not. So thanks. Thank you.